consultant and in Kim's Health Hospitals from Kerala. Ma'am's area of expertise are infectious diseases, general and special population, preventive health and vaccination, and antimicrobial stewardship, and hospital infection control and prevention. Thank you so much, ma'am, for accepting the invitation. Over to you, ma'am.
Okay, very, very good evening to all. So today's topic is on antibiotics, classes, mechanism of action, molecular targets, and resistance. So it is little complicated to finish in 45 minutes or so. So I will try to do my best, and you can resolve your questions, put it in the chat box, or I can handle it together. And this is actually a vast topic. It needs to be taken in multiple sessions, but then since we have a timeline of 6 months, and I will try to do my best. My disclosures for today. This is scientific content, is not AI generated. That is what in this day and age, I think we should all disclose. And most of the references are from manual textbook of infectious disease. So if you want to have any reference, you please go through the chapter on basics in antibiotics, the initial chapters. It's a mammoth topic, hence I will be only highlighting some of the aspects, and I will not be touching on certain things. So this could be a little boring topic. I can't help. I'll try to be make it interactive, hence I have made a pre and post test, so that I can ask you the questions at the end of the session, and you can put the answers in the chat box, so I know that you have understood well. So please be attentive to the pre-test question and the presentation, so that you can answer the post-test questions. And objective of today is classify commonly used antibiotic into major antibiotic classes, mechanism of action of these antibiotics, the resistance mechanism of each, highlight the clinical use of each class of antibiotic. Just only highlight, I will not be going into depth. This use of each antibiotic based on the syndrome will be dealt in the further sessions. And there is a session on drug-bug match for GNB, GPC, and so on, and you will be learning much more than that, practical aspects. Then I'll also be touching upon the antibiotic used for resistant gram-negative, because you should be knowing what are the drugs that are used, be aware of it. Again, there are a lot of development happening in this area. I will not be dwelling on much, but then I will give you just a gist of what is resistant gram-negative bacteria and some newer antibiotics. I will not be touching about PK/PD, side effects, and other things because of out of time. And at the end, I will summarize and with a post-test question. This will be the objective for today. So the pre-test are these 7 questions. One is, what is a major mechanism of action of antibiotics? There may be many. If you can highlight 3 or 4, it would be good. Major mechanism of resistance. 3 major category of penicillin. What is ESBL? Name the common carbapenemases found in India and the drug used to overcome it. Name blind spots of some of the antibiotic. Blind spots means these antibiotic will not act against certain bugs. That you should be knowing, because we should know what is the gaps in the spectrum. That is called blind spots of cephalosporin, carbapenem, TG cycline, colistin, and ceftazidime bacter. Metronidazole need not be added when the following drugs are used. Dash. So this we will try to answer in the post-test. I know many of them, you are microbiologists and some are clinicians, so this may sound very basic, but there are few clinical pharmacists who I have to address. So I am starting with basics. Please bear with me if it is little too much of basics. So antibiotic classification, as you can see in this one slide, if you have to compile in one slide, can be largely classified as cell wall synthesis inhibitor. So, and these are classified that acts on the cell wall, that is the site of action. And these are classified as beta-lactam and non-beta-lactam group. In the beta-lactam group, largely it is divided into penicillin, cephalosporin, carbapenem, and monobactam, which is aztreonam. In the no beta-lactam ring, but acting on the cell wall, you have sulbactam, you will have sulbactam, tazobactam, and clavulanic acid. And then you have, these are also beta-lactam inhibitors. No beta-lactam, you have the drugs, glycopeptide, which acts on the again a cell wall, but it doesn't have a beta-lactam ring. And these are divided into Van-Tico. And we have lipopeptide also, which is daptomycin. And we have polymyxin B and bacitracin. Coming to protein synthesis, which is largely divided into 30S and 50S. And 30S, the drugs acting on 30S ribosome are aminoglycoside and tetracycline. The drugs acting on the 50S are the mainly that we use are macrolide and chloramphenicol and lincosamides, which is clindamycin, and even linezolid acts on the 50S. The drugs that acts on the DNA topoisomerase are mainly fluoroquinolone, which again can be divided into previous generation Norflox, followed by ciproflox, and now the newer generation levoflox and moxifloxacin. Then the large group of drug called the folic acid synthesis main drug. It is again classified as sulfonamides and trimethoprim, and they act against the inhibit the folic acid synthesis. So this is largely the drugs that we commonly use. We also have metronidazole and rifampicin, which we'll not be discussing in detail today. Before we go into the mechanism of action, the antibiotic essential for gram-positive spectrum. These are the drugs when you think a gram-positive infection. Again, what is a syndrome that we think about gram-positive infection will be dealt in drug-bug match as well as the GPC syndrome. But largely, you remember, penicillin, including aminopenicillin, anti-staphylococcal penicillin, that is cloxacillin, flucloxacillin. All these are mainly gram-positive, and anti-staphylococcal penicillin act against MSSA. First and second generation cephalosporin predominantly is gram-positive, tags against MSSA and streptococcal group of drugs, bacteria. Glycopeptides, which are largely Van-Tico, daptomycin, and oxazolindrons groups, that is linezolid, act against MRSA and Enterococcus, including Enterococcus faecium. Clindamycin has coverage against MSSA, MRSA anaerobes. Tetracycline and protramoxol, again, similar coverage, including some of the streptococci, though they are becoming more resistant. TG-cycline, we don't usually use for gram-positive cover. It is a reserved drug for gram-negative organisms, and some of the anaerobic cover, it does cover, but it has cover for MSSA, MRSA, and Enterococci. So if you look at the MRSA cover, is largely from this group of drugs called glycopeptide, daptomycin, that is lipopeptide, linezolid, clindamycin, tetracycline, and protramoxazole are good oral options for MRSA. Coming to gram-negative, we have a huge list, but many are drug resistant to the bacteria, and so we at least 50% of these drugs we cannot be using as empirically. So broad spectrum penicillin, like the anti-pseudomonas penicillin, what we call as piperacillin tazobactam, is it is have a good gram-negative cover. Third and fourth generation cephalosporin, beta-lactamase inhibitor, carbapenems, aminoglycosides, quinolones, monobactam, TG, minocycline. These are later generation tetracycline, polymyxins, fosomycin, chloramphenicol, cotrimoxol, nitrofurantoin, and the new beer BLI, that is ceftazidime avibactam. All these are the main gram-negative backbone. Of this, we are actually, some are outpatient treatments, some are inpatient critically ill patients, and some are used for drug-resistant pathogens like carbapenem-resistant Klebsiella pneumoniae. Drugs used for anaerobic cover are mainly metronidazole and clindamycin. And remember, if you're using beta-lactamase inhibitor like cefoperazone sulbactam or piperacillin tazobactam, carbapenem or TG-cycline, it covers anaerobes and you don't need to add additional metronidazole. So coming to the largely how the drugs act on the bug. So there are different mechanism of action. Some act on the cell wall synthesis, for example, vancomycin and the beta-lactams. Some act on DNA gyrase, for example, ciprofloxacin. Group of drugs act on protein synthesis, as we saw on the first slide. 50S inhibitors are macrolide, chloramphenicol, clindamycin, lincomycin, linezolid. Those act on 30S are tetracycline aminoglycosides. Those act on the folic acid metabolism, trimethoprim and sulfonamide. Those that act on cell cytoplasmic membrane structure is polymyxin and daptomycin. So let us see a touch upon all this in a couple of slides each and understand what is the mechanism and resistance before we go into the large group, that is beta-lactam. So remember, all those that acts on a cell wall or are usually kill the bug immediately, and these are cidal drugs, including daptomycin and polymyxin. But the word cidal doesn't mean it is superior. It is a greatly misunderstood dogma of ID. So one of the dogma in the field of ID is an antimicrobial agent that are cidal are more effective than those that are static. It is not so. Although it may appear that antibiotics may kill rapidly if it is cidal, but when you look at the clinical effectiveness in the large data, the data doesn't support this, and it all depends on the PK/PD, the dosing, and the site of infection, that the outcome matters. It is not only the cidal effect. So coming to a brief, largely outline about the resistance mechanism that we will be touching upon. There are many resistant mechanisms, and it is impossible to explain or understand in one session. But if you can understand that largely there are 5 resistant mechanisms, which in combination may be seen within each bug to actually make the drug ineffective. So let us see the commonest being the enzymatic activation, followed by decreased permeability, that is the bug has a thick coat so that the drug doesn't get in, or the target is blocked or modified by some mutation. Efflux is sporin channel, that is drug is expelled out. Alteration of the target site, which can happen at the cell wall level or at the protein synthesis level. Protection of the target site. These are the 5 major mechanisms of resistance. There are much more, but if you could remember this, it would be good enough. And even one pathogen can have multiple mechanisms. So, for example, this enzymatic inactivation can happen with beta-lactam, as well as a target site inactivation can happen. Similarly, for aminoglycoside, again, it is enzymatic inactivation. If you look at tetracycline, the main mode of mechanism of resistance is efflux. For co-trimoxazole and glycopeptide and clindamycin, it is more of alteration in the target site. So, to explain further, if these are the major mechanisms, like inactivating enzymes, efflux pumps, decreased uptake, alternative enzyme, target alteration, then let us see what are the antibiotics that are inactivated or resistance against these antibiotics developed by which all mechanism. So predominant mode of resistant mechanism by inactivating enzyme is for beta-lactam and aminoglycoside. Efflux mechanism is commonly seen in tetracycline, macrolide, and beta-lactam, especially Pseudomonas group. Decreased uptake is seen in macrolide, glycopeptide, and beta-lactam. The target alteration is commonly seen in macrolide, trimethoprim, fluoroquinolone, glycopeptide, lincosamides, and beta-lactam. And you have alterations and uptake and target alteration is also seen in tetracycline. Also remember, there are many modes of transmission of this bacterial resistant. One is plasmid mediated and other mainly are chromosomal mediated. The best example of a plasmid mediated enzymatic inactivation is the extended spectrum beta-lactamase production. So the beta-lactamase is an enzyme that is produced by the organism, and this is plasmid, that is, it lies outside the chromosome within the cell, and this can be easily transmitted from one back to the other. This is commonly seen in gram-negative bacteria, which develop resistance to beta-lactam antibiotics by this mode. So the resistance can be across the species also, and from organism to organism, like Klebsiella to E. coli and so on. Other antibiotic also of similar enzymatic inactivation is with aminoglycoside, where the enzyme is different, aminoglycoside acetyltransferase. Coming to target alteration. Target alteration is usually chromosomally mediated, and the best example is PBP, that is penicillin binding protein. So look at this diagram. This is penicillin binding protein. When beta-lactam attaches this, then it inactivates so that the plasma membrane, development of plasma membrane doesn't happen and the cell get lysed. So this happens during the development. So if there is an alteration in this so that the beta-lactam cannot bind, then that results in resistance, and this is chromosomally mediated, so it is not rapidly transferred across species. So it is within the chromosome, these genes are there, so it is not that much transmissible. Quinolone DNA gyrase resistance against quinolone is also of chromosomally mediated. The third important mechanism is decreased access to target, which can be due to decreased permeability, as you can see. For example, beta-lactam, the OMP-mediated beta-lactam resistance, or it can be active efflux, which is usually seen in tetracycline, macrolide, and even in beta-lactam. So coming to each category, I will be only having 2 or 3 slides under each category to explain the mechanism and resistance again. This is just to revise or reiterate so that at the end of session, you will know what are the important mechanism of action and resistance. So fluoroquinolone, all this have a quinolone ring. As you can see, this we don't no more use norfloxacin because of the resistance, and ciprofloxacin again is less commonly used because of the resistance in gram-negative bacteria. These are newer generation quinolones, as you can see, moxifloxacin and levofloxacin. These are called respiratory quinolone, and moxifloxacin has action against anaerobes also. So what is the mechanism of action? As I said, it acts on the mechanism of action is acting on the DNA that gyrase, and it inhibits the DNA gyrase, causing relaxation of this. It prevents the relaxation of the supercoiled DNA. So this coiled DNA has to unwind before replication. This unwinding is inhibited by quinolone, and hence the further DNA recombination and repair doesn't happen. So cell death happens. What is the resistance? The main mechanism is decreased uptake, as we discussed. Spontaneously occurring mutation happen, and these are chromosomally mediated. They alter the target enzyme genes, that is DNA gyrase or topoisomerase 4, and they also alter the permeation of the drug into the cell. Spectrum, it is mainly gram-positive, but has a good gram-negative cover. If it is susceptible, it is active against Pseudomonas, Enterobacteriaceae, H. flu, and Neisseria. It is the resistance is very high among gram-negative because of the beta-lactamases that is produced against these agents. It also has a typical bacteria cover, Levoflox against Legionella, and it's a backbone drug for tuberculosis, second-line drug. It is also useful for NTM, Brucella, and many other infections. Coming to macrolide, the older macrolides are erythromycin, and current macrolide that we commonly use are azithromycin and clarithromycin. They have a lactone ring in common. So what is the mechanism of action? We have discussed earlier, that is 50S ribosome That is, it inhibits by acting on the 50S inhibits. So it binds reversibly to the 23S ribosomal RNA of the 50S ribosomal subunit, inhibit the bacterial RNA-dependent protein synthesis and block the translocation. So the elongation doesn't happen. What is a resistant mechanism? Again, the target site is within by causing the target alteration, again by mutation. And there is a gene called erythromycin-resistant methylase, or the gene. These are produced. And this results in high-level resistance. And what it causes is there is structural changes to RNA that prevent the macrolide from binding and allowing synthesis of bacterial protein to continue. So it blocks the RNA-mediated protein synthesis by causing mutation, so that the target alteration happens, so that the drug doesn't bind. And the gene that is most important gene that you have to remember for macrolide resistance is the gene, or the erythromycin-resistant methylase gene. Spectrum of activity, again, yes, if you look at the gram-positive aerobes, that clarithromycin is more effective than erythromycin or azithromycin. It has good action against even MSSA, strep pneumoniae, but we have better drugs for MSSA, so it is not the drug of choice. It can be used for many of the streptococcal infections, but there are a lot of resistance reported among macrolide resistant among mycoplasma. Gram-negative aerobes, again, azithromycin is better and commonly used for salmonella infection than any other gram-negative. And it doesn't have any activity against Enterobacteriaceae. So it should not be used for E. coli or Klebsiella. It is not a great drug for anaerobe. It covers atypical like Mycoplasma, Legionella, and Chlamydia. It also is useful for rickettsial infection like scrub typhus and non-tuberculous mycobacterial infection. It has a very good tissue penetration. And it attains very good levels intracellularly. Coming to tetracycline, a common thing is it has a hydronaphthosine nucleus containing 4 fused rings. Tetracycline is short-acting. We not commonly use it now. The long-acting ones are the doxycycline and minocycline. And the next generation tetracycline is the glycycline group, or the TG cycline, which has a wider spectrum of activity. The mechanism of action is, again, it acts on the 30S ribosome, and it inhibits protein synthesis by blocking the bacterial ribosomal protein synthesis by binding to the 30S ribosomal subunit. Resistance is mainly by efflux. So tetracycline resistance is by efflux, production of ribosomal protection proteins. Also, by causing target alteration, it inhibits inhibits the binding of the drug to cause target alteration. So that the protein synthesis is not inhibited. And other modes of mechanism of resistance is decreased drug permeability and enzymatic degradation. Spectrum of activity of tetracycline is, it is good for many of the gram-positive, though resistance is reported with streptococci. And it is also covers Staph aureus, including MRSA, though the resistance may be up to 20 to 30%. Gram-negative, it is not a great drug, but we have newer drugs like TG cycline, which has a gram-negative spectrum. Atypical organism, it is a very good drug for atypical organism like Mycoplasma, Chlamydia, and Legionella. These are respiratory atypical organisms. It also works well for rickettsial infection, including scrub typhus and other rickettsial infection, leptospirosis, melioidosis as an add-on drug, and many protozoa. TG cycline is the newer tetracycline glycycline group. It is active against many of gram-negative, that is resistant to carbapenem. It has good cover for anaerobe, MRSA, VRE, including atypical organisms. It doesn't cover Pseudomonas, Proteus, and Providentia, the 3P, and the Marchandia. Minocycline is again, now it is more widely used for gram-negative pathogen. And its unique spectrum is it covers Acinetobacter, Stenotrophomonas, Burkholderia group, especially the Burkholderia cepacia, and Elizabeth kingly. It doesn't cover Pseudomonas. Coming to aminoglycoside, we have naturally occurring aminoglycoside, of which all these are important: streptomycin, neomycin, kanamycin, tobramycin, gentamicin. And we have semi-synthetic derivative like amic acid and nitromycin. The mechanism of action is again by binding the 30S ribosome. It inhibits the bacterial protein synthesis. The resistant mechanism is by multiple mechanisms: reduce uptake or active efflux or both, decrease aminoglycoside binding by mutation and methylation of the 16S ribosomal RNA. It can also be inactivated by inactivating enzyme. And using aminoglycoside for a long time can result in bacterial biofilm formation with associated bacterial cell wall surface adhesiveness. Spectrum of activity, it is a wide spectrum. Gram-positive aerobes, usually it is used in combination with beta-lactam, especially if it is in bacteremia other than urinary source. And it covers Staph aureus. It's an add-on drug for Staph aureus and coagulase negative staph by synergistic action. And you can even bring down the duration of therapy in infective endocarditis. It also is effective against viridans, streptococci, and enterococcus species, especially enterococcus fecalis. It also covers gram-negative aerobes, and it can be used if it is found susceptible. It includes Enterobacteriaceae, Pseudomonas group, and many other gram-negative bacteria. It is a good second-line agent for MTB, non-tuberculous mycobacteria, and even Brucella. So that is almost all of the gram-negative cover except beta-lactam, which I will be talking in the last half of the session. Coming to glycopeptide, we are switching to more of gram-positive cover now. So glycopeptide largely is divided into two drugs, that is vancomycin and teicoplanin. And the mechanism of action is cell wall synthesis inhibitor, so it is silent. It inhibits the peptidoglycan synthesis in the bacterial cell wall and prevents cross-linkage of the peptidoglycan chains, which is important for the cell wall of the bacteria. So how does a resistant develops? So there are some difference in how a resistant develops with in Enterococcus and in MRSA. So it's a and VRE, it's a plasmid-mediated gene transfer which confer high-level resistance to vancomycin. And there are two resistant phenotypes called the VAN-A and the VAN-B. VAN-A are resistant to levels of vancomycin and teicoplanin, and both cannot be used if there's a VAN-A-mediated resistance. And VAN-B organisms are resistant to vancomycin, but they are susceptible to teicoplanin. And commonly we find the VAN-A resistant Enterococcus faecae. Coming to vancomycin resistance in Staph aureus, they are classified into H-VISA, that is heterogeneous vancomycin intermediate susceptible Staph aureus, and VISA and vancomycin resistant Staph aureus. These are rare and these are usually developed due to selective pressure on prolonged use, and if the MIC is towards the high cutoff, that is towards 2. Continued exposure leaves uniform population of VSA clones, and VSA has a thicker cell wall along with insufficient cross-linking in the cell wall. The MIC usually creeps between 18 and 16. So how does VRSA develop? It's surprising that it is actually due to a gene transfer. The transfer of VAN-E gene from Enterococcus species occur, resulting in a thick cell membrane of Staph aureus. So if you look at, these are vancomycin susceptible Staph aureus, which can be MRSA, and continued exposure, and if there is an vancomycin enterococci around, then there occurs a gene transfer from this enterococci to the vancomycin susceptible Staph aureus, and over a period this is integrated and becomes VRSA, and this results in a thick wall now of the Staph aureus, so that the vancomycin wouldn't get it. So there is a decreased uptake resulting in resistance. Summary: vancomycin and is a large molecule. It's active only against gram-positive bacteria. It's useful in Staph aureus and enterococci, and orally it can be given for C. difficile, Clostridium, Clostridioides difficile. Daptomycin is a next generation vancomycin, somewhat similar lipopeptide membrane active agent. It is approved for SSTI, staph bacteremia, and right-sided enteritis. But the vancomycin cannot be used whether due to resistance or MIC creep, or if it is a vancomycin resistant enterococci, or if there is contraindication to vancomycin use. Linezolid is a group, it belongs to the group called oxazolidinidones, and it acts by inhibiting the 50S ribosome. The inhibition acts against the early steps as compared to other drugs, and it binds to the V domain of 20S rRNA component of the 50S ribosomal unit. By this mechanism, it causes inhibition of protein synthesis. So again, it results in inhibition of protein synthesis, and that is the mechanism of action. Resistant is by chromosomal mutation that actually prevents the antibiotic binding to the binding site, and that is how the resistant develops. Clinical use is similar to daptomycin and vancomycin. It's used for MRSA, but it's useful like daptomycin to vancomycin resistant enterococci, pneumococcal resistant to penicillin, ceftriaxone, and vancomycin will be the drug of choice. Only alternative drug will be PRS, this linezolid. It is a second line of agent for tuberculosis, so the abuse should be limited. It should be, it should not be abused, not limited. It should not be abused, and we should carefully choose this drug for indicated conditions only. For trimoxazole, otherwise trimethoprim sulfur methoxazole combination, the mechanism of action is folic acid metabolism inhibition. What is PRSP? I will talk about. It is pneumococcal resistant penicillin is penicillin resistant strep pneumonia is called the PRSP. Okay, so it completely inhibit the incorporation of the PABA into the tetrahydroteroic acid. So the folic acid synthesis is inhibited, and this results in decrease in the bacterial nucleotides and bacterial growth. So that is by inhibiting the folic acid synthesis, and it's more or less selectively inhibit the bacterial folic acid synthesis only. So humans are not affected. Resistance by lowered affinity of the sulfonamide, enzyme-mediated drug resistance, and plasmids that decrease the bacterial cell permeability. It is a very good drug. It has a wide action. I have only highlighted a few. It is a good drug for UTI and uropathogens like E. coli and Klebsiella can be used. It is a good drug for Salmonella, melioidosis. It's a backbone drug. It has a very good action against many gram-positive cocci, including Staph aureus. If found sensitive, it can be used for MRSA. It also has atypical cover for many pathogens like Nocardia, non-tuberculous mycobacteria, pneumocystis caris pneumonia, PJP, that is pneumocystis jirovecii, and toxoplasmosis. These are only some of the spectra. It can be used for many other conditions. Coming to beta-lactam. So I have finished a major chunk of multiple antibiotics that I have discussed, but beta-lactam is a big group, so I pushed to the last. So we have discussed about the important drug that you will be using and options that you will have to give during your antibiotic stewardship rounds. And these are importantly, I would like to recap. Starting with macrolide, fluoroquinolone, aminoglycoside, tetracycline, trimoxazole, coming to gram-positive cover, vancomycin, glycopeptide group, including teicoplanin, daptomycin, linezolid. So that sums up almost pretty much important drugs, the mechanism of action, and the drug resistance and the spectrum. Coming to beta-lactam, it's a huge group of drugs, and they all have in common what is called the beta-lactam ring. And there are cephalosporin, which is 5th-generation cephalosporin are there, and carbapenem, and the important carbapenem that we commonly use is meropenem, imipenem, doripenem, and terpenem. and the basic penicillin group. As you can see, it's broadly classified into narrow spectrum and broad spectrum. Narrow spectrum penicillins are benzyl penicillin, penicillin V, flucloxacillin. Broad spectrum are amoxiclav, where you add a BLBLI to the amoxicillin, ampicillin, piperacillin with tazobactam. So, as I said, all this will have a beta-lactam ring, which is common. You find in penicillin, you can find in cephalosporin, carbapenem, and even in the beta-lactamase inhibitor that we use has this beta-lactam ring. Only in the first generation beta-lactam inhibitor like clavulanate, tazobactam, and sulbactam will have this beta-lactam ring. We have newer generation beta-lactam inhibitors, which I'll be talking in the next few slides, that will not have the beta-lactam ring. It will have a different ring. So, if a penicillin is given and if there is a beta-lactamase producing the bacteria, it will open this ring and inactivate, make this penicillin, destroy this ring and make the penicillin inactive. So beta-lactamase is an enzyme produced by the bug which kill the or it or causes the drug inactive by dissolving the beta-lactam ring. But by using a combination with beta-lactamase inhibitor like clavulanate, we are trying to overcome this. So the spectrum of penicillin is very wide depending on which group you select. It covers gram-positive and gram-negative bacteria. It covers anaerobes. The spectrum, as I said, it depends on which penicillin you chose. And it is largely limited by the drug resistance that we will understand slowly. As I said, penicillin is broadly divided into narrow and broad spectrum. But if you look at penicillin GNB, it's morely gram-positive cover, less of gram-negative, except for selected bacteria and anaerobe, bacilli and anaerobe, like anaerobe Clostridium is the best example. Coming to oxacillin, cloxacillin, diclox, fluclox, naphicillin, these are all called as anti-staphylococcal penicillin, and they have good action against MSSA. It doesn't have inaction against MRSA. Coming to aminopenicillin, ampicillin, amoxicillin, again, it is very good for pneumococcal infection, strep group of pathogens, including pneumococci, including Enterococcus faecalis, not faecium, faecalis, and it has good action against viridans group of streptococci, which causes endocarditis. Though there are some amount of drug resistance that are now reported. It doesn't have much actions against gram-negative, mainly because of resistance. Piperacillin is an anti-pseudomodel penicillin. It has a broad cover, including gram-positive and gram-negative. Amoxiclav is by adding BLI, you again have a broadening the cover of penicillin. It has better anaerobic cover as well as some of the gram-negative bacteria like E. coli and Klebsiella is also acted upon. Piperacillin tazobactam is again a broader cover. By adding beta-lactamase inhibitor, we are using it to cover extended spectrum beta-lactamase producing gram-negative bacteria. So it has gram-positive cover and gram-negative cover is much more than the gram-positive cover. So as you go from above down, there is a variable spectrum of cover which you will have to understand. The PRSP is penicillin-resistant strep pneumoniae, and MRSA and E. faecium are the drug-resistant GPC for which we have specific drugs, which will be discussed later when we cover the GPC and GNB chapters. Understanding cephalosporin is even more difficult, so we have to just focus on one bug in each generation, so that drug is commonly used in our practice. So if you cannot by heart live it, it's not possible. So just imagine, understand that we have 5 generations. All first 4 generations doesn't have any activity against MRSA, and the 5th generation only has any action against MRSA. The first generation is IV preparation is cefazolin. It is an anti-staphylococcal cephalosporin, and it's active against MSSA, not MRSA. The oral Sebdon will be cephalexin. Second generation example will be cefuroxime, and the oral step down will be cefuroxime acetate. So this is again, it can be used for MSSA, but this is not the drug of choice. It has mainly gram-positive cover, and to some extent, susceptible E. coli can be covered by this group of second generation cephalosporin. Cefamycin, most of them is not available in India. Third generation cephalosporin, the commonly that we use is cefoperazone, along with the beta-lactam inhibitor combination like sulbactam. Cefotaxime and ceftriaxone are good drugs that are used for salmonella, and has good cover for E. coli if it is found susceptible. Ceftazidime is an anti-pseudomonal third generation cephalosporin that you should remember. That is a main drug for Pseudomonas. If found susceptible, it can be used. It is also the drug that is used for melioidosis and Burkholderia group of pathogens. Fourth generation cephalosporin is cefepime, and this is again an IV preparation. There is no oral preparation in fourth and fifth generation, remember. Again, this is anti-pseudomonal, and this group of drug is used to overcome resistance against AMC, which I will be discussing in the next few slides. AMC is a resistant enzyme where even beta-lactamase inhibitor is not effective, and it can be managed only with fourth generation cephalosporin or carbapenem. The fifth generation, the highlight is it has a very good gram-negative cover also, but doesn't act against ESBL. Its main purpose, again, attraction is it is the only cephalosporin which has an MRSA action. So, to sum up, cephalosporin, as you go from the first to fifth generation, your gram-negative cover is more, your gram-positive cover is less, as you can see, except for a fifth generation, which is good gram-positive cover also, because it covers pneumococci and many other streptococci, including Staph aureus and MRSA. So, but if you look at the cephalosporin, they are all inactivated by beta-lactamase. But as you go up the generation, fourth and fifth, it are more stable, but still it is not a great drug. Sometimes you have to use carbapenem. So blind spots of cephalosporin, you have to remember, it doesn't cover listeria, atypical pathogen like mycoplasma, chlamydia, legionella, MRSA. Only fifth generation cephalosporin works, and enterococci, it doesn't have any cover. So lame is a mnemonic. Cephalosporin has blind spots, and these are the pathogen against, and many other pathogen if there is resistance. But by default, it doesn't act against any of these pathogens. Coming to carbapenem, the commonly used carbapenem, meropenem, imipenem, doripenem, it is all broad spectrum. It can cover GPC, GNB, anaerobes. Ertapenem, remember, it is not against active against Pseudomonas and Acinetobacter. The blind spot for carbapenem is it has no action against MRSA. It doesn't act against Enterococcus except for imipenem, which can act against E. faecalis. It doesn't have any action against atypical organism like Mycoplasma, Chlamydia, Leptospira, and so, I mean, not Leptospira, Mycoplasma and Chlamydia, respiratory atypical organisms. Again, the mechanism of action of all these beta-lactam, that is penicillin, cephalosporin, and carbapenem, is by acting on the cell wall, as you can see, including Astriona. It acts on the cell wall, so it is cell wall lysis, causes cell wall lysis, and it kills the bacteria. Okay, but looking at closer, if you look at the penicillin binding protein is an important mechanism where the the drug bugs binds to the bug and kills the bug, but it is also the important site for resistance. Okay, so penicillin binding proteins is called PBPs. It is membrane-bound enzymes. These drugs act on the PBP and inhibits a transpeptidation, which is the final pathway for the cell wall synthesis. And by this, inhibiting this, it inhibits the cell wall synthesis and causes lysis. Now, I will not be talking about this drug, but in few months, you will learn that this is an important site where cefepime zidibactam, the newer PLBLA, will act. And it is, as I understand, it's a marvelous drug to overcome the resistance produced by these bacteria. Okay, coming to the method of resistance, it is one commonly inactivating enzymes, destruction of the antibiotic by beta-lactamases. Other mechanism is failure to penetrate, efflux pumps, and low affinity of the target site, that is low affinity of the PBPs. Coming to evolution of beta-lactamases, it is not new. From 1961, there are a lot of enzymes, that is beta-lactamases are produced, and every year a new beta-lactamase is identified, starting from TEM1. So now, a decade ago, we had more than 500 beta-lactamase identified and reported worldwide. What is ESBL? It is an enzyme which is plasmid mediated, and it is rapidly spread from one bacteria to other. It is freely lying in the cytoplasm. It hydrolyzes extended spectrum cephalosporin, that is third generation cephalosporin, cefotaxime, ceftriaxone, ceftazidime, as well as aztreonam. How is it overcome? It is by combining with a beta-lactam inhibitor, which inhibits these enzymes. So it is usually combined, and what practically that we use is piperacillin tazobactam or cefoperazone sulbactam. And this resistance is most often seen in E. coli and Klebsiella. So this is the example of a ESBL E. coli, where you find that ceftriaxone is resistant, and you find cefoperazone sulbactam is sensitive, carbapenem is all sensitive, and it is a ESBL pathogen. Coming to AMC beta-lactamase, it is again one type of beta-lactamase, which is not plasmid, but it is chromosomally mediated. It again is a type of beta-lactamase which is inducible, and in here you find that it is not even inhibited by beta-lactamase inhibitor, but it is inhibited by cefepime and carbapenemase. So this is the example of AMC, where you find that BLBL is resistant, but you find that if you get a culture report of cefepime sensitive and carbapenem sensitive, then you suspect that it's an AMC producer. This is only a simple understanding of the resistant mechanism, and there's much more to it. Coming to carbapenemases, that is carbapenem resistant enterobacteriales. There are some bugs which can produce carbapenemases, like beta-lactamase and cephalosporinases. This is a beta-lactamase. Carbapenemase is a beta-lactamase. And there are mainly three classes, A, B, and D. C is the AMC that we discussed earlier. A is KPC, which is widely seen in US. Class B is NDM, WIM, and these are called, other name is called MBL, that is metallobeta-lactamases. It's commonly seen in India. Class D is OXA48. Again, this is commonly seen in India. And all this causes high level resistance. There are other things called non-carbapenemase producing beta-lactamases, and these are due to multiple mechanisms, efflux and decreased permeability. And this is much more common in non-fermenter, like Acantobacter and Pseudomonas. This is an example of carbapenem resistant bug, which is a Klebsiella, where you find all the drug, including the carbapenem resistant, and even polystyrene is methyl. And this we have other drugs to work for this. And these are classified as MDR, XDR, and PDR. And XDR is only two group of drug is susceptible, like fosfomycin or tigecycline, rest is all resistant. PDR is no drug is susceptible. So, as I said, NTM and OXO, allure or combination are common in India. KPC is commonly seen in US. So, we all know the earlier that we have beta-lactamase inhibitor. As I said, that is clavulanate, tazobactam, and sulbactam. These are called first generation beta-lactamase inhibitor. Then we have second generation beta-lactamase inhibitor. These are called DBOs, which I'll explain in the next slide. And the most important thing that you have to understand is the avibactam belong to second generation BLBLI, and otherwise called as a first generation DBO. So this has action against, if you look at ESBL, that is TM, it has activity. CTS is also class A, that is ESBL, and KPC, AMC, and OXO48, but it has no action against the MBL producing pathogens. So if you find your carbapenem producing drug is OXO48 positive, you can still use this. But if it has NDM, this avibactam will not be helping you. So now this avibactam is combination is available with ceftazidime avibactam as available as ceftazidime avibactam combination. Newer BLBLA are in the coming to the market, which I will not be touching upon today. So ceftazidime avibactam is useful for KPC. It is not useful for metallo-beta-lactamases like NDM. That is the most important thing that we'll have to understand. Again, ceftazidime avibactam has no action against acetato. It has action in up to 30% of pseudomonas. But some amount of resistance is expected due to other mechanism like efflux. So how do we overcome this ceftazidime avibactam? How can we make it work against MBL? Is by combining with avibactam. We don't have aztreonam here. So we don't have avibactam, aztreonam avibactam combination here. So we use only aztreonam to bring this combination of ceftazidime avibactam plus aztreonam. By using this combination, we are actually making it work against NDM, which is the commonest pathogen resistance that we find in India. So avibactam, as I said, though it is called beta-lactamase inhibitor, it is a novel beta-lactamase inhibitor. It doesn't have any of the beta-lactam ring that we earlier discussed. No, it doesn't have a beta-lactam ring like first generation. It is totally different. So this is called diazo-bicyclooctane. That's called DAPO ring, and it is totally different. It is it has low propensity for hydrolysis by the bug. So for the first generation, when they attach to the bacteria, it gets killed. It's called suicidal inhibition, but avibactam has a low propensity for hydrolysis, and it bind and also act till it kills the bug. So expanded spectrum, it covers more of the resistant by beta-lactamases, more enzymes. It has an extended spectrum as we saw before. And it is by inhibiting it binds by covalent acylation, which is slowly reversible, and it continues to act. No intrinsic activity. It doesn't have any intrinsic activity. It just enhances the activity of ceftazidime by protecting by degradation by the beta-lactamase, that is AMC and KPC. It doesn't have any action against the MBL. To make it active against NDM, we have to add aztreonam. As aztreonam is added to ceftazidime avibactam, then it can be active against MBL. So this is again the flow chart. If we have beta-lactamase, we are largely divided into serine beta-lactamase and the metallo-beta-lactamase enzyme. So class A is KPC. This ceftazidime avibactam will be effective. Class D, it may be effective. Class B is the MBL producing, where most enzymes are inhibited by avibactam, and this it is overcome by adding aztreonam. This again, the similar one. Class A, avibactam is effective. Class B, KPC, KPC is avibactam is effective. Class B, it is not effective. Class C, AMC, it's effective. And OXO48 producing class D, it's effective. So for MBL producing class B, it is not effective. This is overcome by adding aztreonam. That is why we combine ceftazidime avibactam with aztreonam to overcome this resistance. And in Bet's lab, this is tested by various methods. I'm not going into detail to look at the synergy. So unless you have a synergy test reported, you cannot blindly go on giving ceftazidime avibactam plus aztreonam combination, because some of the E. coli may be resistant to this combination and it can result in failure of treatment. Clinical utility of ceftazidime avibactam, it is active against Enterobacteriaceae as well as Pseudomonas, but it is not active against only against KPC and OXO48, but not against NDM. If for NDM, you have to combine with aztreonam. It doesn't have any action against acetato, anaerobes, or GPC. So if you are giving this for intra-abdominal infection, you have to add metronidazole to this ceftazidime avibactam. But If you're giving piperacillin tazobactam or cefoperazone sulbactam for an abdominal infection, you will not be adding metrogyl because that sulbactam and tazobactam has anaerobic cover, whereas avibactam doesn't have anaerobic cover. This I will skip. I'm not going to talk about this new drug, which we will deal with later during the gram-negative session. Coming to polymyxin, it's a cyclic lipopeptide. It is a surface active agent that disrupts the cell membrane. So it actually binds and inhibits the lipopolysaccharide membrane formation. So cell lysis happen. Again, it is cidal, like daptomycin, like vancomycin. Polymyxins are cidal. And there is a difference between polymyxin B and E. B is E is colistin, where it is so unpredictable, and it is the amount of colistin that you get after you give IV colistin is so unpredictable because of the metabolism, the first renal clearance in the first phase, and conversion of inactive to active molecule is unpredictable. The amount of drug that is converted into active molecule is unpredictable. Whereas polymyxin B is an active drug, and how much ever you give will be in the circulation. The resistance is by plasmid-mediated MCRG, which modify the lipid A of the lipopolysaccharide in the bacterial cell wall, the outer membrane. So the initial, which is the initial target for the polymyxin, and the polymyxin binding and action on the cell wall doesn't happen. Again, this will be dealt with next session when we would compare the use of colistin and polymyxin. So it is active against many gram-negative bacteria, but the blind spots are it doesn't act against Proteus, Providentia, Morganella, Serratia, Burkholderia. Remember, Burkholderia, many of these are nosocomial pathogens. So if a patient develops ongoing infection while on colistin, you have to think about colistin blind spot, that is the gap in the spectrum and coverage. What is the position on colistin? What does IDSA say? Role of polymyxin for the treatment of CRE. It is IDSA says that it doesn't. It is against using the polymyxin and colistin because they have a better drug called ceftazidime avibactam. But again, ceftazidime avibactam alone is not great for India. We have to use aztreonam to overcome the embryo production. Why polymyxin is less and less used? Because of the better drug that we have in combination. They have found that there is increased mortality and nephrotoxicity associated with polymyxin-based regime. And moreover, the accuracy of polymyxin susceptibility reported from lab is always questionable because many lab doesn't follow the broth microdilation, and again the clinical effectiveness when the MIC increases again is a worry. So CLSA has stopped reporting the susceptibility category for colistin and polymyxin. Fosfomycin, again, it is a cell wall acting agent. Again, it is cidal. It blocks the cell wall synthesis, acts on the early steps of beta-lactam ring. It acts in the early steps of the cell wall synthesis, even before the beta-lactam and glycopeptide steps occur. So the spectrum, again, it's a broad spectrum. It against active against GPC, including VRE and MRSA, and extended spectrum. Gram-negative cover is there. It doesn't cover Pseudomonas well. The blind spots again are Acinetobacter, Stenotrophomonas, B. cepacia, Morganella, and anaerobes, except for bacteroids. It doesn't have a great effect on anaerobes. So to sum up, if you want to know the clinical spectrum of this bacteria, you will can go through this slide. So this gives a glance of what is the cover for each of the drug that we have discussed. As you can see, penicillin, among the penicillin, piperacillin is the widest spectrum. It covers, including gram-negative anaerobes also. If you look at cloxacillin, it is mainly gram-positive, no gram-negative. If you look at first and generation, more of gram-positive. Second and third and fifth coming to more of gram-negative. And the vancomycin, Clinda, Dapto, Linezolid, all are gram-positive. Doxy, Tetra, some gram-negative cover. PG is broader cover. And aminoglycoside, phosphomycin, colistin, all belongs to the are for gram-negative cover. So with that, I will come to the post-test. I know it's a very difficult topic, and thanks for listening. And coming to post-test, I think you can now use the chat box to answer each of this. So major mechanism of, can you please answer major mechanism of action? You can either unmute and answer or put it in the chat box. Meanwhile, I will answer this question. What is the difference between E. faecium and fecalis? So actually, these are not E. fecalis doesn't turn into E. faecium by resistance. These are two different bugs and species. So phenotypically, we can identify by looking at the susceptibility and by identification mechanism, which is now in automated machine called Vital. And phenotypically, this fecalis are susceptible to penicillin and ampicillin, whereas faecium phenotypically is resistant to ampicillin, penicillin, and it is susceptible to vancomycin linezolid. So most of you have answered the first question. What is a major mechanism of antibiotics? Yes. Cell wall synthesis inhibition? Yes. Protein synthesis? Yes. DNA gyrase inhibition, folic acid synthesis inhibition. And coming to the second question, major mechanism of resistance. Yes, you have answered. Enzymatic inactivation, efflux pumps decrease permeability and alteration in the target site. Very good. What are the three major categories of penicillin? You can classify in any way, but for practical aspects, you can classify as aminopenicillins, anti-staph penicillin, which is cloxacillin, flucloxacillin, which is active against Staph aureus, anti-pseudomonas, that is piperacillin, tazobactam, piperacillin or piperacillin tazobactam. Yes, you're also right if you write extended spectrum beta penicillins. What is ESBL? Extended spectrum beta lactamase. So how do you identify that? It hydrolyzes third generation cephalosporin and Astriona, but it is sensitive and it is overcome by BLBLI. Name common carbapenemases found in India and drug used to overcome it. What's your answer? Carbapenemases is Indium, Oxa 48. Yes, you're right. What are the drugs that can be used for overcoming it? Name some drugs. Antibiotics. Ceftazidime, avibactam, Astriona. Yes. What else? Polymyxins, yeah. Then minocycline. Minocycline, again, the resistance rates are high. It's more useful for Acinetobacter. What about phosphomycin, tigecycline? And whatever you find. So if you look, so Indium and Oxa are the common. So you can use any of this. Ceftazidime, avibactam plus Astronum, polymyxin, tigecycline, minocycline, phosphomycin, or any other as per the susceptibility. Sometimes you may have to use cotrimoxazole and even chloramphenicol or aminoglycosides based on the susceptibility. What are the blind spots of cephalosporin, carbapenem? This is also very important. You should know what it is not active. You may think carbapenem is universally active against all but you should know what are the gaps in the spectrum. Cephalosporin, we discussed. Yeah. What about carbapenem? No MRSA, enterococcus cover, except imipenem, which can act against enterococcus faecalis. Tigecycline doesn't cover 3P, Pseudomonas, Providentia, Proteus. It doesn't cover Pseudomonas and Morganella. Colistin doesn't cover some of the nosocomial pathogens like Elizabeth Kingia, Burkholder recipicia, Stenotropomonas. Ceftazidime avibactam has no action against TPC and MRSA. It doesn't act against Acinetobacter. So, yeah. So coming to the last question, metronidazole need not be added when any of the following drugs are used. What are they? Yeah, BLBLA, tigecycline, carbapenem. Okay, any of the BLBLA except the newer generation, that is ceftazidime avibactam, doesn't cover anaerobe, but cefoperazone, pip, sulbactam, pip, tazobactam, all this. Again, clindamycin has anaerobic cover. Okay, and with that, I would conclude. And thank you for staying awake. I know this is a tough topic. If you have any questions or any comments or any discussion, anything that you want, please post in the chat box. If you find it very, very difficult to digest, then we will have another class. Extensive topic, but still you covered very well. Thank you so much. If you could share some notes or if you could share the slides, helpful, please, ma'am. Okay. Another question was ceftazidime avibactam and aspirinum cover Pseudomonas, ma'am. Yes, it can be, but actually in the Pseudomonas, the complex mechanism of resistance makes it sometimes fail. Ceftazidime avibactam per se can be effective, but if it is an efflux mediated resistant mechanism, we cannot use. So you have to go by the susceptibility report also, because if you get if you have an in-house a panel that reports these resistant genes, and if they diagnose the pathogen identified as Pseudomonas, and they tell that NDM is not detected, so you cannot straight away use ceftazidime avibactam and think it is working. You have to go by culture susceptibility also, because even if NDM or KPC is not detected, there can be efflux mechanism and the drug can fail. So for Pseudomonas, always a susceptible report is also important. You cannot go by genes only. Then there are other questions. When should we? I think I'll go from above. Yeah. Does ceftazidime avibactam aspirinum cover Pseudomonas? Yes, I have answered. Does carbapenem cover all anaerobes? Yeah, it covers all anaerobes. And what is the next question? Yeah, meropenem sulbactam. Meropenem sulbactam is not a FDA approved drug. Please don't use it. By adding sulbactam to meropenem, there is no added advantage. It doesn't cover Acinetobacter. Meropenem, if it is found resistant, by adding sulbactam, you don't get any advantage. It doesn't cover anything. So that is not an approved drug. You should not be using that combination. Can you share the slides? Then when should we ask for synergy text? It's specific for my particular. So if you find the carbapenem is resistant, okay, you may empirically use colistin or any drug. You will wait for drug susceptibility and you find that carbapenem is resistant. Then they may report for fosomycin, tigecycline, on all those things. But still you may think that fosomycin may be resistant, you may have to use ceftazidime avibactam. So automatically, if there is a carbapenem resistant, the lab should switch over for ceftazidime, proceed with ceftazidime avibactam susceptibility as well as synergy. If the ceftazidime avibactam is not susceptible, they should proceed with synergy testing with aspirinum by doing E-strip or sometime two disc are kept and look for zone of inhibition. So there are standardized protocol for that, which I will not be discussing today. It can be done for E. coli, Klebsiella mainly. Ceftazidime avibactam is mainly used for Klebsiella because E. coli there are other mechanisms of resistance, and only 60 to 70% of ceftazidime avibactam aspirinum is susceptible or will work for E. coli because of other mechanisms of resistance. Similarly for Pseudomonas. So then, any other questions? How does ampicillin sulbactam combination work against Acinetobacter, it is intrinsically resistant to ampicillin? Oh, sulbactam is the main drug for Acinetobacter, not ampicillin. So you can give high dose sulbactam alone, and the approved drug dose is 9 gram per day, which can be given in divided doses, 3 gram each time. And sulbactam can be combined with minocycline or tigecycline or colistin or aminoglycoside, which is reported as susceptible. It is usually used as a monotherapy only for mild infection, combination therapy for moderate to severe infection. Ma'am, who went ESPL mask AMC and Vitek cannot detect, can we routinely test for this mechanism by manual reading? Okay, you can, but I'm not sure. You must be the expert because unless we know, we go by the multiplex PCR panel, which gives all this resistance, including CTX, AMC. It's very easy. Then we know what to add. Carbapenem will be upfront. Otherwise, by in the lab, I'm not sure how we can assess these resistance. There will be resistant mechanism. When we had this testing for carbapenemases, that we had the mechanism to detect MC, but I don't know whether my lab, I don't think my lab is doing. You may be knowing better, Raksha. Can monotherapy with colistin be used for? No, monotherapy is ideally better not used for Acinetobacter unless it's mild. If it's mild, the use is with usually sulbactam. What is an indication for fosomycin used in GMP? It's an add-on therapy. Oral fosomycin is for cystitis, but IV fosomycin is usually an add-on second agent along with a polymyxin or tigecycline or any other backbone as reported if susceptibility is reported. Again, use is mainly for Enterobacteriaceae. It doesn't have any action against Acinetobacter. Okay, then most of the time we use colistin in intermediate susceptibility. How should we interpret this? No, colistin is no more reported as susceptible. Only MIC is given. A lab should not report colistin. If so, you should question it. So colistin MIC may be reported, which you can use it for your own. You can interpret if the MIC less than 0.5, it may or may not work. It may work, you can use it. If it is more than 1 or 2, then you have to suspect that it may not work. So they stopped reporting colistin last 2 years. Can oral fosomycin be used for cystitis? Yes. Can single dose of fosomycin be used? Yes. Oral fosomycin for a simple cystitis, single dose for prostatitis. It is multiple doses depending on whether it is prostatitis. It is given for up to 1 month. And if it is abscess, it needs drainage and combination therapy. And again, it is more useful for E. coli. Some people use high dose sulbactam. Likewise, any guidelines for using avibactam in large dose? No. See, avibactam doesn't have any action by itself. No? It's used to protect ceftazidime getting lysed. And that's all. Can fosfomycin be used for Pseudomonas infection bloodstream? If they report susceptible, you can use in combination because fosfomycin susceptibility itself is a question. There is a different breakpoint for CLSA and UCAST based on disk diffusion and E-strip. So it all depends on which method your lab is reporting and whether it is correct. Anything else? Thank you so much. Thank you. So
thank you so much, ma'am. That was really an excellent session. And actually, it's a vast subject, but yet to try the best to just teach us about the concept, ma'am. Thank you so much, ma'am.
Thank you. I tried my best to not to confuse you.
That was really excellent, ma'am. That was really excellent.
Thank you. Thank you so much and a very good night.
Thank you so much, ma'am. Thank you, ma'am. Thank you all for joining and see you all in the next class. Yes, the